Hi, everyone. As my blurb says, I'm Emil Panzaru, Research Director here at the Consumer Choice Center, and I'm joined today by Sabine Chidiac, who's our Canadian Policy Associate, to talk about everything related to Canadian healthcare, our newest Healthcare Time Saved Index 2025, and unfortunately, some of Sabine's experiences that she can testify about the Canadian healthcare system, what can be done to turn things around, and lessons Canada and other countries can learn about from countries that have performed best in the index. So thank you, Sabine, for joining me today.
Oh, I'm glad to be here, and I'm always happy to talk about Canadian healthcare reform and issues regarding Canadian healthcare policy, which always come up in politics but never really change. So happy to talk about it.
It's interesting because when I looked at some of the most recent polls, I've seen that around 69% of people actually want change. They want healthcare reform. So it's not that there isn't appetite for change, it's that it actually takes political will to look at these things. Thankfully, we've got a handy tool for policymakers and consumers to figure out where their country sits among other advanced healthcare systems. One might have gone wrong, and what we can do about it. As I said, the Healthcare Times Index is a simple composite index with a that relies on 7 different variables to classify 20 of the top healthcare systems in the world. And by top, I mean that we picked out the more prosperous countries so that we don't, let's say, muddle our data with other considerations. So these are the top OECD performing countries. They're at similar GDP per capita. So we can control for that factor and simply look at how well they perform among a range of factors, going from telemedicine from chronic and non-chronic patients, distance to hospital, to the nearest hospital by car, how much they promote innovation in terms of blister packs and pharmacy technology of that sort, all the way to availability of emergency and non-emergency birth control. And as I said, we provide a very clean and simple ranking so that people can understand what's happening there, where we use a simple sum to just aggregate the points related to that. Very easy to understand, very easy to compare, because you can look at all these different factors directly.
Yeah, so I had the chance to actually read the Time Save Index. I think it's really well done, and it mentions Canada a lot because, and not in a good way,
Not good
sadly.
news, unfortunately.
No, not in a good way. We are near the bottom, as you know. We are only beating out Ireland. It's the only country that's below us on the rankings. And, the time save index is all about being more efficient with the time of patients and medical staff. And Canada's second to last. And it's pretty obvious why that is when you live in Canada. Recently, I had something happen to me. It's very minor, not a big deal. But I'm going to relay a story that I think every Canadian has a story like this. I was washing a pot in the middle of the night, like really late at night. I just had to wash it before I went to bed. And a piece of like metal went underneath my nail and my thumb. And it was extremely painful, let me tell you. And I was worried because I couldn't remember the last time that I had gotten a tetanus shot. Tetanus is not something you want to joke around about because after a little while, it really hurts you and sometimes ends in death. You should get your tetanus shot in the first 48 hours after I Googled it. So I felt okay with waiting a little bit. And then the fun really started in the morning. I didn't want to go to the hospital because I knew I'd be there for 16 hours, like 8 hours, 16 hours, who knows? I'd be there all day long. So I started calling around to walk-in clinics. So we call them here walk-in clinics. You just walk in, you're supposed to be seen right away. That never happens. You wait many, many hours. It was around 9:30, 10 a.m. I actually went there because they're too busy to answer the phone. And I told them what's going on with me, and they were very sympathetic, but there physically wasn't any space for me to be there. There just wasn't anyone there to see me. So I was trying to find somebody more local because I needed to get back to work. It was a work day. I needed to do my job until Monday. I already spent half my day driving around finding somebody, everybody rejecting me. And then I just gave up for that day. And I finally went on Tuesday morning to a doctor that would see me. I went to see the doctor and he said, "Oh yeah, this is really bad. You really need to get a tetanus shot." Prescription for a tetanus shot, any pharmacy can have it. Go get one from the pharmacy. I called about 5 pharmacies and none of them had one, because they told me that doctors' offices are given tetanus shots by Public Health Canada, and they're the only ones who have tetanus shots. So the doctor didn't even know that. So Tuesday afternoon at 3:30 p.m., I drove half an hour, 40 minutes to this very far away doctor's office for a nurse to look at my thumb and say, "Oh my god, it's really good that you came in, and it's really good that you came in within 48 hours because this could be a problem." But it took me many hours of my work week, many hours of stress, many hours of calling around. My fiance was calling with me. It was a 2-person job just to find somebody to give me a tetanus shot. And that is just the efficiency of the Canadian healthcare system in a nutshell.
And unfortunately, Sabine, as she said, is one of the lucky ones and one of the people who can work remotely and had the time to
Yes.
spare for all these sorts of things.
I actually mentioned that to my fiance. I was telling him if I worked at Tim Hortons and if I worked at any sort of 9 to 5 job where I have to be in the office, and if my employer wasn't as reasonable as the one I have now, I would be in a lot of trouble.
Indeed. I mean, we know this from international studies that the more this weight goes on, it's a sort of vicious cycle where it leads to higher rates of both morbidity, which means that people get sicker than they would have been if they had been seen earlier, and higher mortality as well, even in some urgent cases, right? It's a recipe for becoming chronically ill in some cases, which puts further strain on the healthcare system, which creates a vicious cycle where things get worse and worse. And this is how Canada ended up in a situation where it has the highest number of people waiting more than a year in among the top healthcare countries in the world. 20% of people, according to the Canadian Medical Association, are waiting more than a year to be seen, more than in the UK, where there's an active discussion around this, around the NHS, more than in France, more than in other countries. And compare that to the highest performers in our index, like the Netherlands, where almost no one that I could find waited more than a year. It rounds down to 0. And if you go on the Canadian Medical Association's website, they say the same thing about the Netherlands. But what can we learn from the Netherlands then if they're performing so much better? Part of it is simply, getting rid of these sorts of hoops that Sabine had to jump through. If you've got a medical record or a medical condition, allow people to share that information with other people, not try and run around for different doctors trying to figure out the same thing at multiple times. That's one. Another one that Sabine is going to get into is just licensing. Canada has one of the lowest number of physicians per capita among these countries. It spends the 4th highest amount in terms of cumulative GDP among OECD countries on healthcare, but it has the lowest amount of physicians, equipment of all sorts, like CT scans, MRIs, among these countries. Part of it is high barriers to entry from licensing. Part of it is what we can talk about more later about not having private-public cooperation. And it's gotten to the critical point, like in the articles, in the academic articles that I've seen and that we've included in the index, the median waiting time is 210 days. For people who are not very familiar with descriptive statistics, that means that 50% of all people wait more than 210 days. They don't wait the full year that the Canadian Medical Association registered, but they wait more than 210 days, which is shocking. It's the highest number in the index by far. For elective surgeries, which is a good indicator of how the rest of the system works, right? As Sabine could see with like ER and walk-in clinics that need to wait hours to see people.
If they see you at all. They told me not to come back. But you have to play doctor because no one's going to see you. And you don't have most Canadians don't have a family doctor. Even if they will see you in 3-4 days, it's better than not being seen at all. But we don't have that.
And there's research on this too. Long waiting times make people delay things even longer. So as I said, it's a vicious cycle. It gets worse.
You talked earlier about Canadians wanting to see reform, and the time save index shows that 73% of Canadians want to see major reform. But that doesn't really add up when you think about the fact that the healthcare system we have in Canada is tied to our national identity. It's really important to us that we have this kind of healthcare, the socialized healthcare in Canada that treats everyone equally. It's very important to us. Unfortunately, what's ending up happening is everyone's being treated equally very poorly. Nobody has any ability to come out feeling better in a less amount of time. And I think a lot of Canadians don't realize that something that you mentioned in the Time Save Index, that Canada is the fourth highest healthcare spending percentage of GDP. So, I don't think that Canadians realize that we're spending so much money on a system that is failing them. It is not efficient. It is not financially efficient. So we're not getting healthcare. It's just that you're not getting it right now.
Yeah. So my economist side is telling me, that to put it in technical terms, healthcare provision is different than healthcare insurance, right? Being able to cover people is vitally important, and it's what doctors and nurses always want to do. But the efficiency of provision, how you actually supply that healthcare, is a matter that should be discussed in terms of how to know how to allocate those resources efficiently, where those MRIs are needed, where doctors' attention is needed. And in the current Canadian healthcare system, this is what's lacking. Because of this publicly funded structure that makes provision publicly funded, not just insurance, not just covering people, making sure that everyone is taken care of. I think that's very important that, you mentioned the 73% for major reform. The other 69 that I mentioned earlier was about people who want public-private provision, who accept that there has to be some level of making sure that doctors don't feel overwhelmed in the system, and that there's enough people who can take care and mobilize those resources. And that comes from the private sector that has a signal called a price system that tells them where those resources are needed at what level. People think that prices are just costs, but they're actually signals of where those resources are needed. The Canadian system really needs to start paying attention to price signals. Otherwise, pay attention only to these time costs that are also a signal, but they're a signal of things going badly. Incorporating that into the Canadian system would not mean that people aren't being covered. We see that from the Netherlands, we see that from Switzerland, that have a mandatory private health insurance system where people are being covered by the government. But they're also able to make it to those providers who are a mix of private, NGOs or all sorts of associations providing healthcare on time, where they don't have to worry about waiting forever and what that means. Another thing is just digital integration of Canada is, unlike Italy and Europe, Canada has made strides towards this sort of getting doctors to use more digital interactions with their patients, so telemedicine of the sort. The problem is that has to be explained to the patients themselves and to be, as I said earlier, integrated into an entire system that works on that basis, rather than switching to paperwork halfway through. I know that doctors don't want the added costs of paperwork for things that they've already done, and we agree. That is a barrier when you don't spend as much time seeing patients as you do doing paperwork.
I do want to say about, going back to our conversation on morbidity, there's an organization in Canada called secondstreet.org. They're a think tank, and they do a lot of work on healthcare reform. And they found that since 2018, they collected data showing that there's been nearly 75,000 waiting list deaths in Canada. If that doesn't serve as a call to arms and figuring out what to do, I don't know what does. I can't imagine losing somebody in my family that I love because they were waiting. They were on a waiting list, or they left the waiting list because they were told it's going to take 3 years to get the surgery. I think that number is really scary to me. We have some great doctors and nurses in Canada. I can't tell you how amazing they are. I've had contact with them for serious issues in the past, for my family and friends, and they've gone above and beyond. We are so lucky to have them, but they're overworked. They cannot do this for much longer. I don't understand how they do it now. I wouldn't be able to operate under that kind of pressure of having to see so many people and only being able to sit with them for like a minute or 2 minutes. Yeah. To figure out what's wrong with them because you have 50 other people waiting outside.
Our index does look at time saved, but we're not saying that you should see people necessarily within 1-2 minutes, because being seen in a short amount of time can also lead to bad outcomes because you're not being seen completely. But the point is that these people would even have the chance to be seen at all when they're not tragic things happen, like we've seen with the 75,000 people whose lives have been lost, who could have potentially have had another outcome.
It's
And
true.
that's just looking at, and that is just looking at the waiting times on existing lists. So not from the moment of diagnosis to treatment, which, as Sabine said, is the moment when people can drop out and you might not be able to see their worse outcome through that. So you're just tracking the numbers on lists, and those are bad enough. Just looking at them, like 2.3 million for knee and hip replacements.
Yes.
It could not be a matter of life and death, but it could still be a matter of living with long-term suffering that you might not otherwise have to live with
Absolutely.
as well.
It's not always just about whether you die or live. It is also about living a good quality of
Living
life.
well, yeah, and
Yeah.
healthily.
So,
Doctors do the best job they can, but they can only work within an existing healthcare system. That is the domain of what policymakers do.
right, and Canada actually, a lot of Canadians look up to countries like Switzerland and the Netherlands than we do. Like, can you
Yeah.
tell me a little bit more about how Switzerland and Netherlands are so high up in the list? And
Yeah. I
maybe we
mean,
could copy that.
even before that, I think that you hit the nail on the head where you said that the actual specter of bad comparison is with the US, right? The fear is that any sort of private involvement of provision results in the US system, right? But it's important to remember that the US system is not anyone's ideal of a free market based
No.
on the fact that it's the highest spender out of all countries on healthcare. Among these OECD countries, 80% of GDP goes towards spending in the United States. And it's still not a market-based arrangement where you've got massive providers, you've got price controls and insurance caps and all these sorts of systems, which you don't get in Switzerland or in the Netherlands. By comparison, the Dutch or the Swiss system demand that everyone gets insurance, but otherwise leave it up to actual consumers to get the choice of what they prefer. There is no mandatory employment insurance. There is mandatory insurance, but it covers more than employment, or it disappears when you're unemployed. It doesn't disappear. You still have it. That creates a system where, as I said before, insurance is there is universal coverage, unlike the United States, but provision is up to actually efficient use of resources. Whereas the United States is, in some sense, a lose-lose system that's trying to compensate for previous interventions by intervening more in the healthcare system.
Right, so to be clear, Canadians do not want to become America when it comes to healthcare. What we want is equal access. In my opinion, looking at this in a policy sense, the only way that we're going to have equal access is if we relieve the backlogs. And the only way we can really do that is if we have a system where people can go to private clinics if they want to, or if they're
Yes.
able to. And I don't want to eliminate access to healthcare for people who can't afford to go to private clinics. That's not the idea here. The idea is that there's a choice, that there's options.
Yep.
There's a consumer choice, if you
Yep.
will, for people to decide for
Yep.
themselves. Maybe I would have paid $150 to be seen right away and got this ridiculous tetanus shot so that I could move on with my life. I might have opted to do that. If I was short on cash, then I would have maybe just waited and gone through that system. But I wouldn't have waited as long as I did because
Yeah.
there would be that relief.
Yep.
There would be other people being able to go and pay that a couple $100s to be seen right away. That means I get to see the public doctor a lot faster because they're out of the system. So for me, it doesn't feel like anyone's losing in the situation. It only feels like we're gaining more of an ability to be seen. There is also an issue, and Emil, I don't know if you can talk about this, but if you want to talk about this, but people worry that the really good doctors are going to go to the private system,
Yeah.
and they're gonna so like people who can't afford it are going to be seen by not the greatest people. Is there any insight into that?
I mean, we've seen with the problems of public healthcare systems from other countries that what actually happens, because of there's this sort of triage within public healthcare systems as well when things start breaking down. It's just that it's based on connections. It's not based on it's not based directly on cash. And as Sabine said, actually letting people pay for some things that are not of high priority clears out the schedule for the people who are a priority, who are going to be seen. So instead of the quality of the doctors, you get the quality of the actual intervention.
That's true. That's really
So
true.
that is, this is an issue across many of the policies that the CCC talks about, including like home ownership, where people talk about home ownership. If we allow expensive houses to be built, that means that there are less affordable there's less housing. Actually, there's more, because the people who would be competing for those services are now competing in another sector. Similar here, right? If you allow for things that are non-urgent to be paid for by people who can afford that, the people who need urgent things can get that stuff from the same doctors, or even higher quality, but seen quicker. So it's,
Exactly.
as I said, that's the allocation I was talking about earlier.
Exactly. So I'd be remiss not to mention foreign credential recognition in this
Right.
conversation too. It's a big issue. I really care about immigration policy, and this has been on my radar for years, how difficult it is to gain foreign credential recognition as a medical professional in this country. And a lot of it really was brought to the center of the conversation during COVID. So I will lead you through this conversation a little bit because it's really important to be had. So if you are a foreign person and you want to come to Canada and you want to work here as a doctor, you've worked in your country as a doctor for 15, 20 years, you've been a nurse for 15, 20 years, you know what you're doing. Perhaps understandably, there are some hoops to jump through. I'm not saying that you should come here and just like become a doctor the next day. There might be some things that you need to have that credential recognition so that you can work in the Canadian system, because systems tend to have some differences, and that's important to realize. Now, the problem is that you have to have a lot done to become a doctor or nurse. Some medical professions need to be citizens before they get a license, even if they're waiting for their citizenship, if they're just waiting for that paperwork to go through, which takes many years. So it takes years. And while you could be working as a doctor, you're actually losing many years of experience. And then when you actually get your citizenship, they say, oh, there's a gap in your resume. You haven't been practicing in 2-3 years. That's too bad. I guess you have to go back to the end of the line and figure out how to get back to where you were before. So that's really frustrating. But the credentialing process is extremely expensive. Costs thousands of dollars in exam and licensing fees. So if you're a new immigrant and you just want to make a better life for yourself, you're already paying a lot of money for your immigration documents, to settle in a new country, to find a place to live, to do all these things and just deal with moving. You're still on the line for thousands of dollars that you may not have. And that's how people end up doing other things that are not in the medical field rather than being the doctors and nurses that they're trained to be. And then we have another aspect in Canada that I find very dark, and that's the guilds, the nursing guilds, the doctors guilds, or the unions that advocate for Canadian prioritization. They work really hard around the clock to limit the number of foreign trained doctors and nurses entering the system, because they want to avoid wage suppression and job competition. They want Canadians to get jobs first. But that might sound correct to some people because, Canada first, Canadians first, right? But Canadians are suffering because of this, because they really need a family doctor. Most of us don't have a family doctor. I waited more than 10 years after moving to Ottawa to find a family doctor. And then I have to go to the walk-in clinic because I don't have a family doctor, who rejects me. So I end up going to the hospital that's already overworked to wait 12 hours to get a bandage on my finger. It's just ridiculous. So these unions are advocating politically for Canadian prioritization. They want to limit the number of foreign trained doctors and nurses entering the system. The international medical graduates, there's not a lot of residency spots for them because of lobbying from these guilds. They don't want there to be. I find that very dark, because these are the people that you trust to have your health top of mind, right?
Yeah,
and if we
and I
don't
feel
change that,
so. In reality, unfortunately, the only thing we can say about this sort of protectionism is that it resolves into a situation where it only benefits the people doing the protectionism and nobody else, because it's an artificial barrier to entry that cripples supply artificially to ensure high prices in terms of labor, out of fear of something that doesn't actually happen.
mm-hmm.
When more migrants come, they also have demand for services, which means that more things get created. The market expands, it doesn't contract. So it's not like, the technical term is just a lump of labor fallacy. There's this fixed lump of labor that exists. And if we introduce more people, then suddenly work shrinks. I mean, think about it. We introduced, we doubled the number of workers at one point. We called that doubling women because women entered the workforce. Did
Yes.
people's salaries collapse when that happened? No. So this is something very similar here. It's not as dramatic than 50% of a population suddenly surging into healthcare. So that might certainly probably help people like Sabine, because there would be a doctor on every corner.
What a dream. You
Yeah,
can just call a doctor's office and say, "Do you want to be my family doctor?" And they say yes.
yeah.
Wow.
So
That
yeah,
would be the dream.
getting rid of unnecessary barriers to entry can do nothing else but help, especially if those barriers have nothing to do with being a doctor, like what Sabine was talking about before. They don't make doctors better. They just make less doctors happy.
And Emil, during the pandemic, there was a
Yeah.
lessening of foreign credential recognition requirements for nurses
Mm-hmm.
because we
Mm-hmm.
were desperate at that point. We needed
Mm-hmm.
nurses so badly, and the system didn't collapse. Can you imagine? We were completely fine. I haven't done the research on this, but I would venture a guess that doctors are not super supportive of their unions doing this because they just want some help. They feel the pressure and they want to relieve that
Yeah.
pressure on themselves.
Yeah.
And the nurses were so relieved to have that extra help. It was wonderful at that time.
Yeah.
It's back to being difficult again. But for that little glimmer of happy days, one nice thing that happened in the pandemic is we allowed nurses to help us more. And that was
Yep.
very good.
Yep. We understand that organizations want to protect the interests of their members, of course, and we can make a reasonable argument for them having a sort of bargaining power that way. But when that bargaining power comes at the expense of consumers or doctors who are not part of those guilds or are part of other guilds, then what you're doing is essentially setting up yourself for a sort of conflict between other people's interests. And in this case, the other people's interests is that waiting list.
Yeah, it's true. Is there anything else you'd like to talk about? Because the time save index is really great. I found it
Thank you.
really, really helpful. I learned things about Canada I didn't know before. I knew it was
Yeah.
bad, but I think that really showed me how bad it is and how easily we can turn it around if there was just some political will to do so. It's very encouraging to see 73% of Canadians want to see major reform. It just makes me feel so good. And 69% of Canadians are willing to open up the system. That's not the impression I get, but that's because I'm in a bubble. And I hear from
Yeah.
advocates, right? And the advocates
Yeah.
are always saying, this is terrible. If we do this, the system will collapse. Poor people will not have access to healthcare. All the good doctors are going to leave for the private system. Like, it's just this echoing of this idea. But the fact that Canadians aren't buying into it anymore, they're tired of this system, gives me hope.
Yeah.
And I think something like the time save index is really helpful because it lays it out in a very easy to understand way, what's going on and how it's working in other countries that we often look up to, like Switzerland and the Netherlands. We always say like their systems are so much better than ours. Well, why? And now we see why.
People forget that there are other systems around the world you can learn from.
Yeah.
You don't need to repeat mistakes by not realizing that those mistakes have happened before to other countries, like Italy or Ireland, or success stories like Denmark or Switzerland or the Netherlands, right? Denmark is also a publicly funded system, but there is a level of competition there between regions that you don't see in Canada. So even allowing for that is a good thing. We know at the CCC, you and me, Sabine, that we've been calling for, regional trade or just paying mind to other provinces within Canada. That working together, learning from success stories like the one in Ontario is even that's a start.
Absolutely. And it's absolutely infuriating to see how much money we spend on healthcare.
Yeah,
that should upset every Canadian.
yeah,
How much money we're throwing into a system that isn't serving us, and we're still paying for all our pharmaceuticals. We're still
yeah.
paying for a lot of like procedures that aren't covered by OHIP.
Yep.
In Ontario, it's called OHIP anyway, but it's called something else in all the other provinces, or the Ontario Healthcare Insurance Program. Not everything is covered, so we don't have a
Yep.
truly socialized system. Like, we're still paying for things. We're just getting worse service. It's very difficult to swallow, I would say, seeing the numbers and realizing what we're actually getting for our money.
And it's unfortunate because there are some good premises, like the fact that Canadian doctors are paid a fee for service. So technically, compared to
Yes.
other systems where there's a fee for fee per hour or something of that sort. They're actually paid, incentivized to see more patients, technically. But there aren't enough doctors, and there's no actual price mechanism to tell you how much compared to how many people are actually waiting. Right, there's no actual ratio that explains this, even in this systems. It's a long-term difficulty, but again, as I think I mentioned this twice before, but it's a matter of political will at this point. It's just you've got people who want to see change. You've got comparisons. You've got this index, very nifty little index you could use to see how other people have done
Yes.
it. It's just a matter of applying lessons. A good place to end.
Yes. I'm really glad that we talked about this today. Thank you.
Thank you as well.